seeing the patient from time to time and knowing the whole patient, one is frequently, like in my case, in a position to put pieces of the puzzle together. And that is very important because of the diversity of neuroendocrine tumors, and each of them with different vasoactive substances. It is incredibly important that one keep it in mind and that you at least have an understanding of the group of neuroendocrine tumors that can present with its syndromes associated with the active hormones that is secreted in these conditions. Even today, with all the biochemical changes and new biomarkers available, it is not very specific, and therefore the clinical suspicion is also very, very important, especially at primary care level. I think that the upskilling of one's knowledge and making sure that you know more about neuroendocrine tumors is very important. Worldwide, they are seeing that the incidence of NETs are rising, and probably because of a greater awareness and therefore earlier diagnosis and more successful treatment. I hope that you will find this inspiring and assist you to want to learn more about the group of diseases and cancers of the neuroendocrine system. My journey with patients with neuroendocrine tumors started about 15 years ago with a patient who presented during an executive health examination with a little bit of increased blood sugar. He told me at that time that he also had a strange metallic taste in his mouth for several months, which did not clear. We tried to get to the bottom of it without success, and a few months later he presented again with chylosis and a bit of stomatitis, which we again could not pin down to anything because his health was good, his blood sugar wasn't really very high, and we just continued to monitor him. After nearly a year, he phoned me one day with a swollen leg, and I realized he had a deep vein thrombosis, referred him. He subsequently had a pulmonary embolism. The specialist treated him for that. I, however, was very concerned about the fact that he didn't really have a reason for his deep vein thrombosis, and I insisted that we do further imaging studies, which the specialist did, and we found on MRI scan that he had a huge tumor of the head of the pancreas. He was then referred to the professor in surgery at one of our very big academic institutions, who phoned me and reported back that the patient had inoperable tumor of the head of the pancreas, and he's referring him back to me for further management. The next day, the prof phoned again to tell me that the professor in radiology suggested that perhaps a neuroendocrine tumor should be considered, which took me back to the books. And this is where, reading through neuroendocrine tumors in general, I saw diabetes, dermatitis, deep vein thrombosis, and dermatitis with the metallic taste in the mouth, realizing that the patient had a glucogonoma. Phoned the prof, diagnosis was made, and the further workup followed. The learning from this for my fellow primary care physicians and family practitioners out there is that you know the whole patient, you know the history over time. And if you want to look at the rarity, the combination in neuroendocrine tumors with syndromes associated with hormonal hypersecretion, weird symptoms that could not be ascribed. The family physician is in the unique position to be able to put the pieces of the puzzle together and to make a diagnosis, which leads to earlier diagnosis, earlier treatment, and better prognosis. So one of the very important points and learnings that came out of my patient after the final diagnosis of a glucogonoma was made is that it drastically changed the prognosis from 3 months with the inoperable carcinoma ahead of the pancreas to what turned out to be a very good quality of life after receiving BRT treatment for 14 years. The important thing from a family practitioner point of view is that one needs to stay involved in managing the whole patient. These patients present with hormonal syndromes and are actually sick and need to be managed. We're not treating only the cancer, we're treating the whole patient. And for that patient to maintain quality of life, the family physician, primary care physician, need to be involved on the whole journey.